But one of the purposes of public health policies that is really important, and I think vitally important for nurses, is the purpose of policy to reduce health disparities. Okay, that is an explicit purpose of public health policies. So what's the relationship between policy, public health policy, and the reduction of health disparities? John Green made a really important observation some 50 years ago. He said, disease only treats humans equally when our social orders treat humans equally. Now, what did he mean by that? He was essentially pointing to the fact that health disparities are avoidable differences in health and health outcomes, and that they occur within people who experience stigma or discrimination in society, or to use his terminologies, who are treated differently by the social order. There's a direct correlation between those groups that are discriminated against, marginalized, and poor health and health outcomes. In the United States, there are a number of key populations that experience consistently health disparities. We've talked a little bit about this in an earlier lecture. Low-income populations, racial and ethnic minorities, sexual and gender minorities, immigrants, new immigrants, as well as religious minorities. Those social backgrounds controlling for all other factors. If you belong to any of these social backgrounds, your chances of experiencing health disparities are much higher than if you did not belong to these social categories, all right? So it's not necessarily a problem within the individual or these communities. It's related to belonging to a stigmatized minority group that creates additional stress and barriers to health that impacts overall health and health disparities. Okay, so I often, when I'm traveling, people understand the importance or the ways in which health disparities can happen in the United States and England, and other countries that are more racially heterogeneous. So we have a very heterogeneous population in terms of languages, race, ethnicities, religious beliefs. And many people can say, well, there are lots of different people who are living in the United States. And so we can understand how health disparities happen there, but they don't happen here. We are all Japanese. We are all Thai. We are all Korean. But it doesn't take much research to very quickly be able to identify that there are disparities in all societies based on demographic and social identities. So for here in Thailand, one of the things that I noticed when I first started to come almost 12 years ago is I looked at the people that I saw, and I saw a wide variety of skin tones, some lighter skin tones, some darker skin tones, some much darker skin tones come close to mine. But when I looked at the advertisements, billboards, commercials, magazines, there was no skin tone diversity, only one, very, very light complected. I thought that's interesting to me. I wonder what that means on a larger scale. And then I looked to see who was in charge, who had office jobs, who had gardening jobs, who had street vendor jobs. From my observations, it didn't take me very long to see that there was a very strong correlation between the status of your job and your skin tone. So if we looked at that much more systematically, I can imagine that there are many of the same types of health and opportunity disparities here in Thailand that we see in other countries based on skin tone. Now, this might be a little bit of a controversial thing for me to say as an outsider, but it's based on my observation now of 12 years of coming here. So we see it in India. India, same thing. We're a homogeneous population, but they see differences based on caste. And in Eastern Europe, we saw in the 90s genocide based on differences in religious beliefs, right? So all societies experience health inequalities, and they're most likely linked to social categories that are stigmatized versus non-stigmatized. Now, what are the drivers of health disparities? Many people, for a long time, when we were looking at health disparities based on race, ethnicity in the United States, it was looking at individual level risk factors. These people smoke too much. These people eat too much. They eat the wrong things. Um, but we started to look beyond the individual level characteristics and started to look at larger social factors, things that we call the social determinants of health. Social determinants of health are things like education, access to health care, the types of neighborhoods that one lives in, the social and community connections, as well as economic opportunities. These are shown to differ dramatically based on social identities. If you are low income, you have less access to these positive social determinants of health. If you are a racial ethnic minority, you have less access to these health promoting social determinants of health. And over time, we have stopped looking as much at individual behaviors and started to explore and examine the relationship between social determinants of health. So, for example, research shows to us that 40% of the risk for poor health is related to one's social economic status. Again, regardless of your health risk behaviors and everything else, 40% of those people who are in poor health are low income. Low, 20% who are experiencing poor health have barriers to access to care. 10% relates to the environment that people live in, related to their housing, their air pollution, their public safety. Only 30% of health is driven by individual risk behaviors. So that tells us that we should be spending less time on changing individual risk behaviors and more time trying to address the larger social determinants of health. Now, as a psychologist, I remain very interested in individual health behaviors and health change. I focus on smoking cessation. But I also am considering the role of access to appropriate smoking cessation treatments in the healthcare environment for low income people as a social determinant of higher rates of smoking and smoking related outcomes. So I'm looking at what looks like an individual level risk behavior, personal smoking, and I'm looking at access to care as a structural factor that is driving disparities. Okay. So now what role does policy have in that? We know, again, that there are groups who have different health outcomes. So in my area of tobacco, we see very strong disparities in terms of the health risk associated with smoking. So even though Black Americans smoke at the same rates as whites, smoke fewer cigarettes per day than other groups, are more likely to start smoking at a later age, compared to all other groups, Black individuals have worse outcomes related to smoking. You would think that if a group smokes at the same rate as other groups, that we wouldn't see any disparities. But let's look at one smoking-related health outcome. This slide on the left shows lung cancer incidence rates, prevalence, and on the right, it shows lung cancer death rates. The colored lines are related to racial ethnic groups. The top red line is related to Black men. We can see from this group that since the late 90s to mid 2000s and currently, Black men are much more likely to develop lung cancer and much more likely to die from lung cancer compared to all over other groups. That is a phenomenon called as the African American smoking paradox. That means we have worse outcomes in a group that doesn't have any higher rates of the risk factors. That leads us to understand this is a paradox. Why is this happening? So, public policy can be very instrumental in addressing the social drivers or the root causes of health disparities. We see lots of health disparities based on low income. And there was a public health initiative that was started 10 years ago and provided more resources this past year. It's called the Cancer Moonshot. That means that the government has put a lot of resources in the reduction of cancer and cancer disparities among Americans. And in this past year, our president has directed additional resources to focus specifically on cancer in low income communities. And so the Biden administration is interested in policy and research that helps to overcome health cancer related disparities among low income in communities with the goal of addressing social and structural determinants of health. Okay. So public policies can serve to eliminate health disparities, but public policies can also exacerbate or make worse public health policy. Well, how can that be? By the same ways that adding resources to help eliminate a problem, like with cancer and low income, we can fail to take action on risk factors associated with disparities. And let me give you one specific example. In 2009, Congress passed the Family Smoking Prevention and Tobacco Control Act. That act was specifically put in place to reduce smoking among adolescents as a way of preventing future cancers. The policy was focused on adolescents. It specifically banned flavoring in tobaccos because youth are much more attracted to flavorings like bubblegum and cherry and other flavors in tobacco. And it also, for the first time, gave the Food and Drug Administration the ability to regulate the tobacco industry. We would all think that's a good thing, right? But let's look a little closer. In that policy, they banned all tobacco flavoring with the exception of menthol cigarettes. Menthol is a flavoring. It's mint, like peppermint. And you may be familiar with menthol flavored cigarettes here in Thailand. All flavors were banned in the US with the exception of menthol. Let's look at why that's a problem. Menthol, if the goal was to eliminate smoking among children, the data shows that the primary flavoring that we should have banned should have been menthol, right? Because the vast majority of adolescents who smoke a mentholated brand of tobacco, right? If we were going to ban a flavor, we should have started with menthol. Another thing that we observe is that we see racial and ethnic differences in the rates of menthol use among adolescents. 71% of Black adolescents who smoke a mentholated brand. And Blacks are a health disparity population. So the research also shows that youth who smoke a methylated brand are more likely to go on to be regular smokers than youth who are non-menthol smokers. All right. So again, evidence suggesting that if we were going to reduce teen smoking, we could start with menthol. Here's the evidence that suggests that that finding is true, that youth who start with menthol continue with menthol. 71% of Black men who smoke a menthol-related cigarette, it now goes to over 85% among Black adults. Black adults smoke menthol cigarettes at 2 to 3 times that rate of the general population. Also, think about the Black smoking paradox, right? There's something related to this issue with menthol. Given that the Food and Drug Administration was given authority to regulate menthol and to study it, the government funded several studies looking at, is there additional harm associated with menthol? Well, they found that menthol was much more highly addictive than other types of cigarettes, right? People who smoke menthol have a harder time quitting, have higher levels, objective measures of nicotine dependency. And now let's look at the data as it relates to ability to quit smoking. So we have for a long time pointed to the high rates of smoking among Black population as related to an individual risk factor of smoking. But when you look at the data, African Americans are much more likely to say they want to quit, much more likely to have made a quit attempt in the past year compared to other groups. But where the disparity lies is because Blacks are almost 100% of Blacks smoke a mentholated cigarette. They're less likely to be able to successfully quit. Why? Because menthol cigarettes are much more addictive than non-menthol related cigarettes. We believe that menthol plays an important role in this smoking paradox for African Americans. So in 2013, the Food and Drug, and this is now 4 years after Congress passed the Family Tobacco Control Act, 4 years later, the Food and Drug Administration concluded that menthol cigarettes pose a public health risk over and above that seen with non-menthol cigarettes. Why? Because it was made inhalation easier. It had that cooling effect, so it was easier for younger people to tolerate it. It was much associated with much stronger addiction. It was harder to quit, and it was associated with smoking disparities among adults, right? There's the evidence. We think that public policy is driven by evidence. So what should have happened? What should have happened in 2013? The public policy was driven by evidence. What should Congress have done? Right. In 2013, Congress should have added menthol flavoring to the national ban on flavored cigarettes. They did not. In 2023, they still had not, despite a lot of policy, despite a lot of evidence, and given assurances by the Biden administration that they were going to ban alcohol last year. But 3 months ago, he said he's waiting. So that tells us that something beyond research and evidence drives decision-making around policy. Now let's look at it from an overall public health perspective. If menthol cigarettes had been banned in 2009, when all the other flavors were banned, look what that would have had. Look what projected impact that would have had for overall national smoking rates. And the group that was likely to benefit the most from that ban would have been African Americans. So they have projected by 2050, 600,000 lives would have been saved if menthol would have been banned with the other flavorings. And that 1/3 of those deaths associated with lung cancer would have been among African Americans. Okay? Why do you think that is? Why do you think menthol is still not, despite all the evidence, why do you think menthol is still not banned? Why do you think that public health policy has not been successful in banning menthol? Say what's on your mind.
I think it's the company that produce the menthol cigarette maybe has something hidden agenda with the government.
Yes.
That I think.
Yes. That's part of it. What else? So the tobacco industry is a strong lobbyist, and they very much support governors and senators and pay a lot of money. So tobacco industry has a lot of influence. But why weren't they influential in getting the others, keeping the other flavors on the market? And we're only looking at menthol that they have been effective with. Why do you think that is? Anyone have any ideas? Anyone have any ideas?
Again, please, for the question.
Yeah.
Again, please, for the question.
Oh, why do you think menthol is still not banned in the United States, despite all the evidence? Why is menthol still not banned?
May I ask for your clarification a little bit? I'm not sure, do you understand about menthol or not? You understand, right? Okay. อาจารย์ไม่ได้พูดถึงบุหรี่อาจารย์พูดถึง menthol เข้าใจเนาะโอเค
In my opinion, I think menthol have some benefit in for health. I think this menthol is can make some people is can good feeling, relax. When he's stressed, I think that menthol is have some benefits.
Okay, all right. Anyone else want to add to that? Now, keep in mind, we're talking about menthol cigarettes. So peppermint, scents, all those other things, that's perfectly fine. But now we're talking about menthol specifically within a known cancer-causing agent to cigarettes, tobacco. Well, let me give you the answer. It's plain and simple as this. The social group that is at the bottom of the social hierarchy in United States are Black Americans. This is an issue that primarily impacts Black Americans because public policy is set by people and officials. Many of those same people who have negative attitudes about Black people are the ones who are making policy and legislation. So senators made the agreement at the time, and this is well documented, that they were going to lose the battle for banning the other flavors if they fought for the inclusion of menthol. So the government decided that, okay, we'll let menthol go and deal with these other flavors. But why? And again, I'm a scholar activist, meaning my work as a researcher is directly aimed at improving equality and equality in health. There's no other explanation than the fact that Black populations in the United States are seen as expendable. And that was the primary reason why menthol was not banned at the time, because all those legislators look and they say, well, this is something that's just addresses as the Black community. That's not everybody. So let the Black community deal with this, as if the Black community and the health of the Black community does not represent public health. Translate? Everyone understand or need some translation? Translation or understand? Translation. So menthol hasn't been banned because of racism in the United States. African Americans are the lowest social status of any group in the United States. Menthol is perceived to be a problem within the Black community. That doesn't impact us. And so in order to move along legislation that was seen to impact rural Americans, they agreed to keep menthol on the market. It was a compromise with the tobacco industry.
โอเค อาจารย์ก็สรุปว่าเมนทอลที่มันยังไม่โดนแบนเนี่ยเพราะว่าจริงๆเมนทอลเนี่ยมันส่วนใหญ่ถูกใช้ในกลุ่มแอฟริกันอเมริกันหรือคนผิวดำนะครับซึ่งไม่ได้มีผลกระทบต่อกลุ่มประชากรส่วนใหญ่ซึ่งเป็นประชากรผิวขาวอาจารย์ก็เลยบอกว่ารัฐบาลก็เลยไม่แบนเพราะว่ามันไม่ได้ส่งผลกระทบต่อคนส่วนมากแล้วก็มันก็จะมีส่วนเอี่ยวกับบริษัทผลิตบุหรี่หรืออะไรต่างๆซึ่งก็แสดงให้เห็นถึง health disparity เนาะคือความไม่เท่าเทียมกันอันเนื่องมาจากสีผิวหรือเชื้อชาติลักษณะแบบนั้นครับ
So this is a very clear, I was shocked to learn that the majority of public health policy is not driven by research because the action would be clear if we only looked at the research. Unfortunately, a lot of public policy is driven by elected officials who don't understand the research, who don't commit research, but it's based on opinion. And so it is vitally important for nurses to be, as a discipline, to be much more involved in the creation of and support of equitable public health policies. So let's talk about that. So what is the role of the nurse in helping to lead public health policy? So nurses can advocate for evidence-based policies. They can conduct research that is policy relevant. So for example, if there is a policy that is being debated, nurses can direct resources and research efforts to provide solid data on that question. So myself and other researchers, after menthol was failed to be banned, we conducted a lot of systematic research that led to the findings that menthol is much more addictive. Treatment outcomes, I'm publishing a paper right now that shows treatment outcomes for menthol smokers are worse in LGBT populations in other ways. So conducting research that is relevant to policies, advocating within your nursing societies for evidence-based policies, and most importantly, developing as a professional society, as a specific college, and as individual researchers, relationships with policymakers so that you can help provide guidance on the development of policy, be able to give guidance on the evaluation of policy to help identify, is this fair? Is this equitable? Is this the right thing to do? And your powerful voices as a nursing association can help to ensure that these things happen. All right, so how do we do it? There are a number of steps for nurse researchers to be involved in policy. And let's talk about each of those. The first relates to conducting policy relevant research. Now, what does that mean? All of us are engaging and thinking about health-related problems. As I showed you in the earlier slide, many of the health challenges faced are appropriately managed by public policy. Vaccinations, seatbelts, helmets. As you think about your area of research, start to think about, are there policies in place that should be able to help this? Can we expand that? Or are there policies that are not speaking to this issue that should be advocated for by my research. So one thing that I started to notice right away when I came to this country is that a lot of people rode motorcycles. Adults had motorcycle helmets on, the children did not. I thought, what? In the United States, if there's one helmet, the helmet goes to the child, not the adult. And I could not understand why was this happening. And I learned that it's a law that the driver only must have a helmet on. And the other riders, including children, it is not a necessity. And those nurses who are focusing on pediatric health and injury reduction, that is something that should be tackled immediately. Looking at the research about level of head injuries due to motorcycle accidents by the failure to legislate all children on a motorcycle must have a helmet. That's a public policy initiative that would have immediate impact on adolescent health. Okay, so those of you, anybody around who's studying adolescent health, that's a good project for you. So how do you start that work? You start to look at hospital records. What percentage of children are coming in with head injuries? What are the factors associated with those head injuries? You are very likely to show a large number of head injuries among children 10 and under are related to motorcycle or scooter accidents. What's the literature say about the protection of reduction of head injuries if helmets are worn by children who riding bicycles or skateboards or other types of things? The evidence is quite clear. Now you can use that information to start to work with lobbyists, the Pediatric Health Association, the Nurses Association, to get a policy in place. Now, one of the things that I would try to do first, and I'm completely off track with this, but I can't help but tell you this. One of the things that I would first do is I would try to get a grant from my institution or from the government to do a pilot program that all children age 5 and under would be given a free helmet. The grant would be focused on distributing free helmets among low-income communities for all children age 5 and under. I would evaluate that program for 3 to 5 years and evaluate what's the consistency of use, how do we educate parents about use, but more importantly, what's the direct relationship between that helmet availability and that policy for the reduction in hospitalizations of children with pediatric head injuries due to motorcycle accidents. That's an example of taking a problem that is staring us right in the eyes, that has a direct solution to, that is under the rubric of nurses, pediatric nurses, injury prevention, that has a policy in place for adults that should be followed by adolescents. All right, so that's an example of how we conduct policy relevant research. Now, what do we do after that? We disseminate our findings related to our pilot project, the fact that kids are wearing them, parents are in agreement, emergency room admissions are down, and then I would report on that in the public in the journals, at conferences, but more importantly to pediatric health associations, right? Go to the nursing association, go to the medical association, have a meeting with the minister of health in your country and show them the data related to head injuries, your pilot program, and the reduction of head injuries as a result of your pilot program. Now, you're disseminating with those. Now you're starting to get people's attention. Now, who are the decision makers as it relates to this type of policy change? I would think the Minister of Health would be a strong decision maker. So I would ask to work with individuals who were in the Ministry of Health who had direct oversight of adolescent health and start to work with them, help them to understand the literature on this, help them to understand your findings associated with your pilot program, the fact that there was a reduction in accidents, and then summarize this evidence for them in a one-page document. This is the key. This is where nurses are vitally important, nurse researchers and clinicians are vitally important in shaping public policy. You meet with policy decision makers and you provide them in a clear, short, digestible, easily understandable document that says, here's the problem, here's the evidence, and here are the potential recommendations that might help that. And here are the results of our pilot study showing the benefits of that policy. Work with collaborators and legislators and other stakeholders in having those discussions. Now you want to raise advocacy. Now you form a group of parents who have lost a child to a head injury or have a severely disabled child due to a head injury. Now they are strong advocates. Many legislators, many people will not listen to a scientist, but if a panel of family members comes and speaks to the legislator and say, my child, this is what happened to my child. This policy would help this. I want you to change this policy to save other children's lives in Thailand. That is a crucial ingredient. Getting community buy-in, community engagement, and to train family members who are directly impacted to join you in this advocacy efforts. And then finally, again, working with them to all along the way to talk about the policy, get other stakeholders in to compare the policy with what's already in place with adults, make it in alignment, show how it's enforceable, et cetera, et cetera. And then finally, that can often lead to public policy change. Once the policy has been changed, your job as a nurse researcher is not over. Now you have an opportunity to do a nationwide evaluation of the health improvement associated with this public policy. Okay? And so now you can look at you can look at the hospital records across the country for the period 5 years before the legislation and for the 5 years after the legislation to show strong evidence of where it's working, where it's not working. Where it's not working is typically related to enforcement, and then you can retarget your efforts to those areas in which there is lax enforcement. Okay? So that's how it goes. So by following these type of steps, it is possible to move public health forward. Now, it takes time. It takes time. This is not an overnight kind of activity. Sometimes it is, like if something very, very dramatic happens, like what was happening in the United States around vaping among teens. We had 200 teens that were suddenly in the hospital and dying, and the risk factor was using a vaping pen. Policy changed immediately. Why? Because the advocacy groups, parents, tobacco control experts, pediatricians came out in full force. And within 6-month period of time, we had legislation, all right? Sometimes it happens quickly. Most time it takes time and it requires sort of a willingness to be very dedicated to this issue. So let me give you an example of some work that took us 5 years to bring into fruition. But before I do that, any questions about policy, the relationship to public health policy and health disparities, and the example of policy research that nurses could do that we just talked about, the helmet law. Any questions about any of those things? Anyone online? I see some things online. Anyone on? No? Okay. Question, comment. What do you think? What do you think about that? The idea of public health policy aimed at increasing helmet use, legislating helmet use among all children where on a scooter. What do you think about that? Good idea? Good idea, right? That's how public policy starts. Someone saying, drawing attention to a problem that has a clear solution to it, and starting to talk to people who can bring about change. There's someone who's going to hear this conversation. There's one of you in this room, or there's going to be someone that someone here is going to talk to about this issue, and someone is going to move it forward, right? It's public policy is driven by humans, by people, and all of us here are potentially able to bring about very important public policy changes. It's possible. Maybe someone here, it's possible. All right, so let me give you a quick example. This is some work that myself and a very large team and diverse team of people worked on for about 5 years, and the work is ongoing. One of my works is around LGBT health disparities, and especially among trans and gender nonconforming individuals. We see high rates of depression, anxiety, and suicidality in these populations. Why? High rates of discrimination. One of the areas that a lot of discrimination and potential violence takes place and harassment takes place is around accessing a public accommodation. Now, a public accommodation that all of us use every single day, multiple times a day, is the toilet, is the restroom. Now, people think, what the heck? What's the restroom got to do with public policy or reduction of health disparities? Oh my God. Well, the fact that the women in this building can have a restroom to use is based on public policy. In the 40s, very few women were in the workforce, and the gender roles and norms were that most women, their lives were lived in the household. Men lives were in the street, in business, in institutions. There were very few places for that women could use the toilet in public society. Now, what happened in the 1940s? We had a world war. United States and other parts of the world, women had to men left, women had to run the factories. Women had to run the institutions and the businesses. Women had nowhere to pee. Public policy at that point that legislated that all facilities had to have at least one restroom for women to use. Because now women were in society. So restroom bills have been around for a long time, and they have impacted the lives of some of us in this room. Now, when you think about trans and gender nonconforming people, well, how does that relate to restrooms? Well, most people are very anxious when they go to the restroom. It's a private thing. And when someone who comes in who may identify as a woman or as a man, but has a different appearance, it can bring hostility, it can bring threats and potential for violence. As a result, many trans people will not use the restroom in public. one of the main non-communicable health disorders in the trans community is bladder and kidney infection from persistent holding of urine until they can find a place to safely access the restroom. So that is a problem that I have encountered on numerous occasions. And so I was sitting around one day. A friend of mine, a couple years prior to this, said, "You know what, Phoenix, they're doing some interesting work in Philadelphia on the restrooms for trans people. Let's get involved." I said, "I have no time for that. I have no time for that. It's good work. I have no time." And then I'm in a community that I think is an LGBT community, big community there. I go to the restroom and I'm almost assaulted by two men who thought I was a man going into the women's restroom. And it was quite eye-opening. It was not the first time, but it was the first time I was almost physically assaulted. And I thought, this is the karma for me not taking action when it was first brought to me. And at that point, I dedicated myself to working on public policy related to fair access, safe access to restrooms among trans and gender nonconforming people. We developed a group called the Chicago Restroom Access Project. Dean, if you're listening, please cover your ears. Chicago Restroom Access Project is affectionately known as CRAP. If you know your English slang, that is a word for something you do in the restroom. So it's a university and community collaboration where our goal was to change the public policy that all single-stalled restrooms, meaning there's one door, there's one toilet, one person uses it at a time, like the one here around the corner, that instead of saying women and men, it should say restroom. There is anybody who needs to use the restroom should be able to use one that is for one person at a time. So we needed to do a number of things. We needed to build our stakeholders. Who else is interested in this issue? Certainly members of the trans and gender nonconforming communities, LGBT general social activists, local aldermen and women, and believe it or not, the disability community. We had strong advocacy and support from the disability community. Why? I might be a male caring for an elderly, my parent, my mother, who is not able to go to the restroom on her own. I might have her out in public and I can't take her to the restroom. She has a disability. There's no way for her to publicly access a gendered restroom. So the disability community was on board. Parents were on board. Father testified, I have a daughter. I have to make the decision to go to the men's room where there's no changing table and try to change my daughter's diaper. Or I could try to go to the women's room where the changing table is and get arrested. What am I to do as a parent? Because now more men are raising children and bringing them into public on their own. So we had a lot of unexpected stakeholders. So our goal was to get input from a lot of different groups. We collected data collection. Remember, what were the key principles? Identifying a problem that's eligible for change, getting your stakeholders, understanding the evidence around it, and then working with legislators. So we got a lot of different data to help support us, because we knew we were going to have to talk to people who are biased against trans. One of the things that we knew they were going to say is that, well, if you do this, men will dress up as women and go to the women's room and assault women. Well, we're talking about one restroom, one person at a time. The person goes in and locks the door. That's not possible. And here's all the data that suggests that businesses are in support, people are in support. And where it's happening, there have been no problems. So we provided education materials. We went before the city council and addressed another bias ordinance that was related to trans. We worked with state policymakers, and we were introduced a bill into the legislation that would change restroom reform. We had the evidence, we provided a lot of guidance. We collected survey of almost 700 people about what the sign should look like. So we had a lot of community buy-in. And I'm proud to say that in 2020, it became a law in the state of Illinois that all single stall restrooms in all restaurants, schools, and other places of public accommodation had to be marked as all gender. So a single person on a mission who gathers a team around them can bring about positive change. So that's our time. We have time for one question or one or two questions or comments.
If you have question, please feel free to share, or even though leave it in the chat box. For those who are sitting here, do you have any questions?
Yeah, please talk to me.
Please do so.
Please talk to me. What do you think? How are you feeling? What are your reactions to this craziness I've been talking about?
Yes,
Any of you
students.
interested? Yes, Dean, please come on.
Yeah. Hi, Dr. Matthew.
Hello.
Hi, thank you for your presentation. And I want students to ask questions, to share your ideas, because this is the policy session. And yes, we need your, how can I say, you should share what you have seen and what do you think. And yes, before this session, we talk about the policy making process already. And I think today, Dr. Matthew give you a clear picture how to move, how to make a policy, especially by using, the research that we are academic person and we can write the policy by doing the research. That means it is the beginning of, it's like when we want to force some policymaker to do something, and yes, we help them to set the agenda setting by we propose or we launch, the findings of the research. That is the clear picture. So I think I want to hear your questions, students, or your ideas. No translation, huh?
She requests me.
Yeah.
Anyone working on anything that they think policy is important for at this point? Anyone working on an area in which there's policy implications?
Yeah, I want to ask you too. Like, I'm not sure that all of you have your dissertation topic already or not, or you may have chance to change it. Something, any one of you interested to drive the policy by your research or not? You want to share? Use the microphone.
Yeah, thank you, Professor. After that, I don't know what I can make the policy why. I think in the เขาเรียกว่าอะไรเป็นคนเล็กๆค่ะ I can
English,
try
please.
to
English. Yeah.
I think I try to make my research station in my problem in my research station. I think I can เป็นส่วนเล็กๆในการที่จะchange social in the past in the future. Okay, thank you, Professor.
Yeah.
Please introduce yourself first and then talk.
Yes.
Thank you เด่นละอองค่ะ I think in my dissertation I can apply or follow the health policy in this country to review and to study in the important issue for the example is teenage pregnancy in Thailand. Yes.
So what are the policies around sex education in schools or the availability of contraception or the ability for teens to go to visit the health nurse without and get contraception? Are there policies in place about those types of issues? Because those have been shown to be really effective to reduce teen pregnancies. Yeah. Mhm. Yes.
Yes. I interest about
Can you please introduce yourself a little bit? Introduce yourself. Yeah. The name.
อังคณาค่ะอาจารย์อังคณาหมอนทองI think I interest about mental health and psychiatric nursing in community. I think I survey and review literature about policy in mental health and psychiatric patient in my Ratchaburi province. I think policy help me for survey dissertation solving problem in patient ค่ะ
So one of the things that we see is a lot of discrimination among of people with mental health disorders in educational and workplaces. So it would be sort of interesting to think about looking at the laws and hiring practices that may discriminate based on mental health history as something that should be overturned. Because there are some people with mental health problems who are unable to work, but there are a lot of people with no mental health problems who are unable to work, right?
Yeah.
Just because I have a history of depression or have a history of a mental illness or hospitalization, that doesn't mean that I haven't been rehabilitated and recovered and now I'm able to work. And so employment policies are definitely one of the areas in which we see a big role for public policy, especially as it relates to mental health care. Yeah.
Okay, Professor, my name is Suthat Suphanam. I am lecturer from the St. Teresa International College, and this time after I listen about the public policy. This time I try to think about the problems in the cardiac patients after they have acute coronary syndrome and they have doctor that have the diagnosis by cardiac catheterizations, and the patient have makes a balloons and insert the stents to dilate the vessel. And after this, I have the problem, I see the problem that's occur in this patients. They readmissions because of after they that's procedure the doctor they give the medicine about antiplatelets or anticoagulant, and while in the 6 months and in a long time to try to blood vessel is good to pumping in the heart muscles. But in the problems in many hospitals, the incident rate of about readmission for patient in this group may be increased. I think when the public policy is making about the prevents or control that problems
Mm.
to decrease about the readmission rate
Mhm,
in patient
mhm,
in this group.
mhm,
Maybe like this, Professor.
mhm, mhm. Now, is that a public policy or is that an evidence-based practice issue? What do we think? Is that an example of a public policy or is that an issue related to evidence-based practice?
Supat, what do you think?
My name is Suri. I think it may be a best practice.
Yeah,
Uh-huh.
yeah. I think that's closer. It's good because you're seeing a problem in a patient population directly resulting to a practice behavior that should be reevaluated. And so your research can definitely influence changes in the way that this is managed in a health system and way. But public policy is when a law comes down from the government that has an implication for improving safety. So you've got a good evidence-based nursing issue that your research will be very important for, but it's a little bit different from public policy. Yeah.
Thank you, Professor.
Mhm.
My name is Vachiri. So when I heard your professor lie about, I appreciate that you are always room. It's wonderful for me. That's it. You can change social for equally. Yes. And in the future, I think I interested in field psychiatric. Yes. When I saw especially student nurse, someone have a psychiatric problem, and when she use net, she have a stigma and do not take some medicine because bullying. Yes. I think in the future, if policy driven equally for psychiatric health problem in China.
Excuse me, I cannot hear.
So that was a good example of an area in which public health policy around anti-discrimination, include education and other workforce, as well as thinking about whether the additional resources that individuals with a variety of disabilities need to have greater inclusion into the society.
Okay. The last one.
Last one. Okay.
My name is it's amazing and very impressed about your valuable project, and it's opened my worldview about how to make a policy. Okay, and for my interested, I'm interested in the home-based NCD patient. It's like a model. So I'm not sure that the dissertation that I gonna be conduct in the future, it can be go on beyond to the policy or not, but I get the idea from your project. And now I think about more than about my project, because my personal I work as a part-time nurse about handspan coordinator. I found that the recipient is too much more than the donor. So it would be better if we can make a policy about everyone can be a donor. We can reduce waiting time of the recipient, and about the blood donation. very is important because now we will heard about the lack of the blood. Like especially about the AB group. And if everyone can donate, like one time a year or twice time a year for yourself, because we don't know in the future maybe we have to use the blood and can use blood for myself. I think
That's interesting. Could we legislate or strongly encourage an infrastructure that would allow for annual blood donation from everyone? Very important. That's out of the box thinking. Well done. All right.
Yeah.
This has been
I
fantastic.
think we have 2 students
Oh, okay, okay.
online.
Yeah.
Online? Okay, okay.
Good afternoon, Professor. My name is Chanita Paskun. I'm interested healthcare policy. I think is a big issue for me. And I work in area of the maternal and child health. I think the healthcare policy about my area, I think I interest the exclusive breastfeeding for the 6 newborn. And
Yeah. Okay. And as you're thinking about developing your research, I would encourage you to think about what are some potential policy implications for from what my research that I'm doing. Yeah. And again, some of us, it's easier for us to see, but stay open to the idea that your research could be an important contribution to public health policy change.
Okay. From is the last student. My name is Komkai Subanapong.
Nice to meet you.
I'm registered nurse in Northeast Hospital. I think it's a health policy and policy of health is a far of me because I have the practitioner nurse. I think it's my dissertation is the right up to the health policy in the next future. In this my field, I have the interest cardiovascular patient with arrhythmia. It's the same as AF and SVT. It's the mostly have the increment in hospital in number 9. The name is not Nakhon Chaiburin. Have the policy to screening for the cardiac arrhythmia. I think have to my dissertation is screening from the unpredicted symptom in the cardiac arrhythmia. My professor, I think in the future.
Yeah. So a combination of work that informs evidence-based practice, that's policy, right? As well as legal and institutional change. That's also important areas. So think about these issues as you're developing your research, as you're going through your research careers, and as you're going to through your day-to-day life. If you see things that are happening to people that are unfair and can be changed by a change in the law, go for it. All right.
Dr. Matthew, could you please? I have a short questions. Yeah, I'm very interested when you talk about, yes, the policy cannot be success when we write the policy, it cannot success in overnight or one day or within the short period of time. And do you have any techniques, right? If we want to move forward and want to change, and we see this is a big issue, but when we propose the policy, when we propose the issue and the policy maker, they feel like, oh, maybe they don't interested in it. Yeah. You have any ideas or for us to, how can we move some
Oh.
issue that we see it's big, but some the policy, the people at the policy level, maybe they don't see like that.
Yeah, yeah. And that's an excellent point. It's the art of the pivot. You know that? The art of the pivot. So that if you are moving in one direction, trying a strategy to achieve a goal, and you get blocked there, the blockage doesn't mean stop. It means you have to make an adjustment and try another route. And over the course of 5 years plus, our group had to pivot in many, many different ways. And so something that we initially thought was going to be our route ended up being completely different from what we ultimately needed to do. But it was still okay, what next? Who else do we? It was typically this question. Now, given what we just found out, who else do we need to invite to the table? And that was typically another type of government official, or typically someone else who was a part of a major organization, or maybe it was a community activist. But we just say, okay, this is the problem, this is the barrier, who else do we need to talk to? So if their policy can happen at the province level, it could happen at the town level, it could happen at the national level, it could happen at the hospital level. So their policy initiatives can be directed at number different levels. Our initial goal was to go for Chicago only for our restroom bill. But we found that working with real policy advocates, they said, no, your best shot at this is to go to the state. And we went, we can't do it. And they're like, yes, you can, let's go. And so we bypassed the city of Chicago altogether. And we just go to the state. And it happened for us. So being willing not to give up, and also to know right this minute might not be the time. So we were working with the legislators, the advocates at the State House to introduce the bill about the restroom. They're like, no, we can't introduce it this session because of this, this, and this. We believe in it, we're going to do it, but it will not pass now. We don't have enough votes. Give us let's wait until 6 months from now to do some more work with the legislators. We think it can pass then, but not right now. We said, okay, that's still encouraging. So the short answer is be persistent. Okay. All right. This has been fantastic. I have to catch a plane, so I should say goodbye, party people.
Dean Brickmon, would you like to say something to thank you, Professor Dr. Matthews?
Yeah, I want to say hundreds of times of thank you. I don't know how to say, but I think this is invaluable session that even every student feel like, oh, policy is too far from us, but actually it's not far. Actually, it's our responsibility to when we see some issue, when we see something and we need something change in our society or in healthcare. Yes, I think that's our duty. And yes, today, I think the students and also me, I got a lot of ideas. And when you go, I mean, in detail about the example, yes, I think I got a lot of ideas to move forward something about the health issue. And I also think that our students have, I mean, see the way to go, not just only in terms of like when you feel like, oh, I am in practical level, I'm not in the policymaker level, but you should be, and you should do it. And now I think you know the way to go. Thank you so much, Dr. Matthew.
Thank you. Thank you.
Thank you so much. So Dr. Matthew gonna leave soon, but before they leave, can we take a group photo together? Please go to this front camera and stand close to Dr. Matthews. You're gonna get a capture. Yeah, go.
Come on,
Please.
come
Yes.
on. I told you I warn before I bite. Come on.
For other, please feel free to turn on the camera and we will take a photo together. Counting down 3, 2, 1.
One more
One
time.
more, one more time. We need more. 1, 2, 3.
Suthat, keep closer.
Oh, so that click closer. Okay, we need one more then. Okay, 1, 2, 3. Thank you, everyone. Thank you so much. Thank you so much.
Okay, students. Students, I will I want 5 minutes to talk to you, and we make appointment for this evening session because Dr. Mayuri, she's the one who will take a part of the session today. So and right now she supervises students in the setting. That's mean she want to maybe you can go back and take your time, and at 4 p.m. we will online to discuss about the policy that you are interested in and select the policy for seminar, and we will give you the ideas. And I think because the policy session, the seminar session, we separate you into 2 groups. And yes, you can talk with each other what kind of policy that you are interested in. And today we will, if you have some idea and you can propose some idea about the policy that you interest, and we can guide you further what you're gonna do in the next step. Okay. So I think, you can take your time and talk to your friends and talk to your group, and propose your ideas when we meet at 4 p.m. Okay, I think I will take time like just only 1 hour to for this evening, and after that we will guide you what to go further on the seminar session. Okay.
Okay,
Okay, very nice participation today. Yeah.
Okay ค่ะ see you
Yes, see you ค่ะ